Hello. Before we begin our discussions on the drugs that will be used for diabetes mellitus, let us talk a little bit about diabetes mellitus first. So this slide set will talk about or will give you an overview of what diabetes mellitus is all about and why we need to control blood sugar. Now, before we begin to talk about insulin and the oral agents, as future nurses, you need to know why we need to control blood sugar. In order for you to properly counsel patients, you need to be able to work with them and realize the need for controlling blood sugar. And after that, we'll talk about how to control blood sugar through not only pharmacologic agents, but also lifestyle approaches. When we begin to talk about insulin and the oral agents, we'll first talk about dynamics or how the drug works. What is its mechanism of action? And what could possibly be the adverse drug reactions? Then we'll talk about drug disposition or pharmacokinetics. How are drugs absorbed, distributed, metabolized, and even excreted, or how they get out of the body. And finally, of course, you will be teaching patients how to take drugs. And so you need a strong background on pharmacotherapy. So first, let's talk about why we need to control blood sugar. You need to realize that elevated blood sugar is toxic. There's a term called glucotoxicity. High blood sugar is not good for many of the organs of the body. And for many patients, the main reason why you want to control blood sugar is to control symptoms of hyperglycemia. Realize that glucose is an osmotic agent, meaning it attracts water. So, when your blood sugar is high, it is excreted out in the kidney, and water follows. And that's the reason why you urinate a lot. At night, you wake up to urinate. That's called nocturia. You also urinate a lot of urine, a huge volume of urine, and that's called polyuria. Polyuria, or frequent and voluminous urination. That's the first of the three P's: polyuria, polydipsia, and polyphagia. Polydipsia is frequent drinking because of the dehydration, the loss of water in your urine. That's polydipsia. And polyphagia is frequent eating because even if your blood sugar is high, it cannot be utilized. So you feel hungry and you eat more actually. So for many patients, that's the reason why you need to control the blood sugar. But many more patients are actually asymptomatic even if their blood sugars are high. So why control blood sugar? Because of the complications. Remember I said that glucose is toxic and glucose tends to bind to our proteins, especially the basement membranes of the proteins that make up the many tissues in the body, including the retina and the capillaries or the blood vessels, no, that supply, for example, the glomerulus of our kidneys or the small blood vessels that supply our nerves. And so when the blood vessels of the eye are involved, there can be some retinal hemorrhages, and eventually that can lead to blindness. That problem is called retinopathy. When the problem is in the kidney, no, the kidney can gradually become damaged, leading to end-stage renal disease, and that leads to dialysis. And finally, because of the damage to the blood vessels of the nerves degenerate so that you develop numbness of the hands and the feet. Eventually, that can lead to wounds, no, and ulcers that become infected, leading to amputations. And so now diabetes is already the number one cause of blindness in the adult working population. It's the number one cause of end-stage renal disease leading to dialysis in the Philippines. And it's the number one cause of non-traumatic amputations. So that's why we need to control blood sugar in order to improve the quality of life of persons with diabetes so that they don't go blind, they will not go to dialysis, and they will not have any amputations. Diabetes frequently coexists with other comorbid conditions like hypertension, dyslipidemia, and obesity. In order for us to lengthen the life, no, of our patients with diabetes, we need to also not only lower down the blood sugar, but also to control blood pressure and high cholesterol. And that is to prevent the macrovascular complications, the problems in the medium and large arteries that are a result of atherosclerotic plaque formation due to high cholesterol, high blood pressure, as well as diabetes. So for the microvascular complications, diabetes has the major impact. But for macrovascular complications, you not only have to control diabetes, but also hypertension, high cholesterol, and increased weight in order to prevent heart attacks, cardiovascular diseases, strokes, cerebrovascular diseases, and peripheral vascular diseases or peripheral arterial diseases, because hyperglycemia is the root cause of the tissue damage to all of these organs and tissues in the body. Now, in order to treat diabetes, we need to know what it is. And this is the classical definition of diabetes from the WHO, which defines it as a metabolic disorder of multiple etiology characterized by chronic hyperglycemia with disturbances of carbohydrate, fat, and protein metabolism resulting from defects in insulin secretion, insulin action, or both. So let's cut down this definition and realize what's important. First, it's that it has multiple etiologies. So there are many different reasons for why you can develop diabetes. It is characterized by chronic high blood sugar. And so once you're diagnosed with diabetes, it's a diagnosis for life. And the disturbances are not only with regards to carbohydrates, but also fat and protein metabolism. So cholesterol is high and they lose a lot of weight. And the two main problems are you don't have enough insulin, insulin deficiency, or there's a resistance to insulin action. Apart from these two main problems, there is one other main defect. So let's take a look at these three different groups, no, of organs. In the main, one of the main problems is in the islet cells, no, of the pancreas, and there are two main islet cells: the beta cell, which is mainly affected by diabetes, where the beta cell produces less insulin. There's also a problem in the alpha cell of the pancreas that, on the other hand, produces excess glucagon, while the beta cell degenerates and dies off the process of apoptosis. The beta cell produces less insulin. On the other hand, the alpha cells proliferate and they produce excess glucagon, which is a counter-regulatory hormone of insulin. So imagine the two should be in perfect balance. The beta cells producing enough insulin and the alpha cells also producing just enough glucagon to counteract the insulin so that we don't go into hypoglycemia. Imagine, therefore, if you have too little insulin and too much glucagon, so your blood sugar will go up because of that. Coupled with that problem is the fact that there's also a resistance to insulin action in the peripheral tissues. The disposition of glucose from the blood going into the muscle, no, for storage and for use of the muscle is decreased because of the insulin resistance. So there's a decrease in glucose uptake. All these, no, especially the excess glucagon and the increased insulin, will lead to a dysregulation of the function of the liver so that the liver now produces excess glucose. Remember that our liver is a very active and dynamic organ. At night or when we sleep, when we fast, our liver actually continues to manufacture glucose. And under the influence of enough insulin and enough glucagon, it will produce just enough glucose. However, when you have too little insulin and too much glucagon, there is now a dysregulation of hepatic gluconeogenesis so that you have an excess in glucose output. All of this leads, therefore, to hyperglycemia or high blood sugar. Aside from these three main defects, what are the three main defects? There's a problem, there's an islet cell problem, there's an excessive hepatic glucose output, and there's insulin resistance in the muscle and adipose tissue. There are defects. In fact, there are 8 that have been counted. So first again will be the beta cell. Then you have the increased hepatic glucose production. You have a decrease in glucose disposition or uptake in the muscle and increase in lipolysis of the adipose tissue. But there is also an increase in glucagon secretion in the alpha cell. Aside from that, you also have too little secretion of another hormone called the incretin. So hopefully you remember this from physiology. GLP-1, for example, that GLP-1 or that incretin signals actually the beta cell to produce insulin during the post-meal period. So how many is that? 1, 2, 3, 4, 5, 6. There are 2 more. The next defect is in the kidney, where the kidney continues to reabsorb glucose even when our blood sugar is high. The natural adaptive response should have been that as our blood sugar goes up and it exceeds 180, it should all go out in our urine. And that happens early on in type 2 diabetes. But somehow some resistance develops so that even as our blood sugars already go up, our kidneys continue to reabsorb glucose. Finally, it has also been documented that there is a neurotransmitter dysfunction in diabetes. These are all mainly in type 2 diabetes. And this is the reason why stress, lack of sleep, or even poor sleeping habits affect our brain. No? And that also leads to dysregulation of certain neurotransmitters like dopamine, which also leads to hyperglycemia. So these are the 8 different defects in diabetes, especially in type 2 diabetes. I began to talk about already the types of diabetes, and there are actually mainly 3 main types: type 1, type 2, and gestational diabetes. Type 1 is a result of beta cell destruction. It's very easy to think about type 1 diabetes because the beta cells get destroyed. They get absolutely destroyed so that there's an absolute insulin deficiency, so that in time they become insulin dependent. Type 2 diabetes is the more variable. It's the one that I was talking about, the 8 different defects that may happen. That can happen in type 2 diabetes. There's also gestational diabetes or diabetes that's first discovered during pregnancy, and it's a transient form of diabetes. As the mother delivers, typically the diabetes also resolves. But this is important because it predicts future risk of diabetes for mainly the mother, but also the offspring. There are also other specific types of diabetes which are more uncommon, like the congenital and genetic ones. But there are also drug-induced diabetes, like, for example, your steroids, can cause hyperglycemia. And this slide just then takes you back to the types of diabetes for you to realize the approach to treatment. Again, type 1 diabetes is an absolute absence of insulin from the pancreas. And so they're insulin dependent. This is called the juvenile type of diabetes, and therefore type 1 diabetes is almost always found in the pediatric age group. There is a genetic basis for type 1 diabetes, but it's typically not inherited. And the approach to treating type 1 diabetes is really by providing insulin. Now, type 2 diabetes is the run-of-the-mill diabetes, and it's the more common of the two. And in the Philippines, practically 95% of all persons with diabetes have type 2 diabetes. It's the adult form of diabetes where the problem is not only insulin secretory defect, but typically insulin resistance. And while the greater majority of persons with type 2 diabetes will not require insulin, around 30% may require insulin later in life or once faced with acute problems that require hospitalization. Type 2 diabetes is inherited and it's linked to obesity. So, if any one of you has first-degree relatives who have diabetes, parents, siblings, or even grandparents who have diabetes, you are at risk of developing type 2 diabetes. Now, to wind up this discussion, let us just take a look at the natural history of type 2 diabetes so that you realize that type 2 diabetes does not develop overnight. While you may be born with a predisposition to type 2 diabetes because your parents have it, it is typically an interaction between environmental factors and your genetic predisposition that leads to insulin resistance. What do I mean by that? You may have a family history, but if you exercise and eat healthily, then you will not probably develop insulin resistance. But if you have a family history and you have an unhealthy, high caloric, high fat diet, or you hardly exercise or you're physically inactive, then you gain weight and you may develop insulin resistance, which is fine while we're young because our pancreas can cope with the resistance to insulin action by just making more insulin, leading to hyperinsulinemia. So that for a long, long time, several years, you actually have normal glucose tolerance. Your blood sugar does not go up. However, if you continue to have insulin resistance over several years, eventually the pancreatic beta cells develop some sort of fatigue and they start to die off. The concept of beta cell failure. So once the beta cells start to undergo apoptosis, they begin to die off, then the insulin secretion begins to wane, and so you develop an increase in your blood sugar called impaired glucose tolerance, and in time your blood sugar goes up and you exceed the threshold, and then you now develop type 2 diabetes. We treat type 2 diabetes with both pharmacologic and non-pharmacologic therapy at this point, but in reality, we need to intervene early in order to prevent its development. At this point, when you don't yet have diabetes, it's still entirely reversible. But once you have crossed the threshold and you have type 2 diabetes, then it's a diagnosis for life. Now, the components of diabetes management are as follows in order for you to realize that it's not just pharmacologic therapy. Treatment will not be successful if patients are not well educated and if they do not also eat properly. And so they need to be taught about medical nutrition therapy, and we work with dietitians and nutritionists, and regular exercise and physical activity is also needed. However, generally, even for patients who are newly diagnosed with type 2 diabetes, an initial regimen of proper nutrition and exercise will not suffice. And pharmacologic therapy is the general rule for most types of diabetes, especially for type 1 and type 2 diabetes. And so, in the next slide set, we will begin to talk about the different pharmacologic approaches to the treatment of type 1 as well as type 2 diabetes mellitus.